So the first abstract we'll be seeing is the EB-CTCG meta-analysis of the latest updates. So it is about the anthracycline and taxane usage in the early operable breast cancer, which includes the 86 randomized trials, like including 1 lakh patients. So the previous meta-analysis, we have the evidence that compared to no chemotherapy versus administering anthracycline and taxane, it reduced the breast cancer mortality by 40% in the first decade after treatment, irrespective of the age and the tumor biology. But does this outweigh the risk involved in a low risk early stage disease is one question we should be answering. So this meta-analysis, it consists of 86 trials, predominantly done before 2012 to give time for adequate follow-up, included both adjuvant and neoadjuvant trials. So the key points which were looked after in this meta-analysis were comparing the trials containing taxane with or without anthracycline, and containing anthracycline with or without taxanes, comparing anthracycline versus taxane, and the sequencing of both the drugs, comparing paclitaxel versus docetaxel, and the fractionation of the taxanes, and exposure of the drug in terms of longer or shorter exposure, along with the higher or lower cumulative dosing. So the primary outcomes were mainly the recurrence of invasive disease and the mortality. So the pre-specified subgroups were according to the follow-ups, the site of recurrence, age, BMI, and the other conventional tumor parameters. But this meta-analysis was done in the era where the genomic profile was not being routinely used as how we use it today. So the first question which we would have been seeing is the use of taxane with or without anthracycline. So it consists of 4 scenarios where anthracycline was given either sequentially with taxane or concurrently with taxane, or without anthras like taxane with capecitabine or with carboplatin. So this constituted like 23 trials, and the results. So the results is like adding anthracycline to the taxane backbone, it reduces the recurrence by 14%. This was mainly predominantly seen when anthracycline was added concurrently to the docetaxel and cyclophosphamide when compared with the same dose of docetaxel and cyclophosphamide. At 10 years, the risk was 12% against 21% on adding anthracycline. But this did not contribute to any increase in death, but there was one additional AML post-treatment which was reported in every 1 in 700 women treated. So this shows that the concurrent administration compared with the same total dose of TC, so this had the maximum benefit. So this again shows the first 2 questions which we saw. So the majority of them had benefit when both the drugs were given. And this is the other 2 scenarios where anthracycline was not included, and capecitabine or carboplatin was the third drug which was used. Even in this, it favored the usage of anthracycline. So this is the second thing which we will be looking into, whether we can give anthracycline with or without exposing them to taxane. So again, like the first question here also, adding taxane showed the largest recurrence reduction when the cumulative dose in the comparator arm of the anthracycline was kept the same. So this graph again shows the difference in the recurrence and in the mortality rates. So when the other thing is when anthracycline is not being exposed, but with the higher dose of non-taxane regimens, the difference was very minimal. And the third scenario is whether anthra versus taxane. The comparison showed that whenever the higher cumulative doses and more intense regimens protocols were used, it showed to be efficacious. And sequencing anthracycline versus taxane did not really show any significant difference in the 10-year analysis. And comparing paclitaxel versus docetaxel, so the difference in the proportional reductions with the schedules of more 2 weekly or a 3 weekly compared with the weekly schedule was highly significant. When it came to the 3 weekly regimen, the docetaxel was superior to paclitaxel, and in the weekly regimens, the pacli was having the lesser recurrence rate when compared to a weekly docetaxel. But when we look into the overall results, definitely docetaxel had better recurrence reduction in the studies compared to paclitaxel. And coming to the fractionation, the overall results did not show any difference in the recurrence rates with fractionation. But however, within the individual drugs, for example, if paclitaxel is considered, the weekly had fewer recurrences when compared to the 3 weekly. Probably the larger cumulative dose at the end after 12 cycles of weekly with the higher dose intensity might explain the more effectivity. But when it came to docetaxel, the 3 weekly docetaxel actually had better results with lesser recurrences. So coming to the longer versus shorter exposure, so most of the trials compared in the analysis were either 6 cycles versus 4 cycles, and JAPA trio compared 8 cycles versus 6 cycles of uh, docetaxel along with AC given every 3 weeks. Across all the trials, there was a more reduction in the recurrences when the drug exposure was for a longer duration. And coming to the overall cumulative dose, so those patients who had a higher cumulative dose had more reduction in the recurrence risk at 10-year analysis, around 14%. But this was seen when the difference in the dose of doxorubicin was exceeding 100 mg or epirubicin was exceeding 150 mg. And this was also noted when the non-anthracycline drug is also given in a higher cumulative dose. This was more prominent. Coming to the toxicities, despite the individual studies reporting more incidence in the cardiac toxicities with anthracycline, the overall there was not much apparent increase in the death rates or the overall mortality rates in those patients who has received anthracycline. But definitely yes, those who had already a pre-existing cardiac risk, it was most of the trials had excluded, and the median follow-up trials in these anthracycline based, it was only 5 years. So the available data on the short term toxicity showed that no consistent difference in grade 3 or the higher toxicities, whether with or without anthracycline. So the authors have concluded that the larger benefit was achieved by adding anthracycline to taxane regimen. And it also confirms that even in early stage who are having higher risk and who are fit enough to receive chemotherapy, combination would be ideal choice rather than exposing them to single drug. And the regimens with higher cumulative dose had the greatest benefit. So coming to the some of the points, so it's one of the largest data with 1 lakh population, but applicability in the era of genomic testing, because most of these trials were randomized before 2012. So we have had a lot of data after that. And the benefit of combination, yes, but in patients with an early breast cancer with more HER2 positive and hormone, where they get the opportunity to do recurrence risk scoring, so this would be a questionable thing. And higher cumulative dose showed benefit. The latest trials have actually started to de-escalate or avoid anthracycline in many of the settings. So whether we can apply this results in the current setting is questionable. And the recurrence reduced irrespective of the tumor biology. So can we really apply this to all the 4 subtypes is again something we should look into. And the proportional reduction in the hazard was correlating with a higher dose, but how do we choose the right dose for which patient is one thing. And the grade 3 or more toxicities did not differ even in the short term or in the long term. So again the latest trials where the comparator had omitted anthracycline in many of the trials. So this is again something which, how do we apply this analysis in the current practice, is something we should be looking into. So the conclusion is benefit is proven to reduce the recurrence and the mortality. Like I said, the more adding more chemo in the HER2 positive and the hormonal disease should be weighed against even in the conventional dosing we are thinking of. So the higher dosing is something might not be in the current situation. So, and also to decide the adjuvant treatment or in the neoadjuvant, the type of disease biology is many times we consider whether we go for an dual anti-HER2 or even post surgical adjuvant. So in those situations, the essential role of both the chemo regimens remains little questionable. And coming to the next abstract,
Your time is over. It's only 20 seconds
I'll
are
just
left.
finish.
So
Yeah. So
just
next
come
is
to the conclusion
sure.
slide.
So next is using neoadjuvant immunotherapy in a triple negative breast cancer. This basically looked into four latest trials where four different drugs has been used, like pembro, atizo, and durva, and pembro, with different clinical criterias and conclusions. So the methods used were the individual patient level analysis and the trial level meta-analysis. So I would just skip all this. Yeah, so only
Just
one.
come to the conclusion slide. I cannot give you any more
So the
time. Sorry.
meta-analysis reinforced the long-term benefit of neoadjuvant immunotherapy in the triple negative setting, which we have data up to like 4 years right now. So the use of neoadjuvant immunotherapy is coming all the way, especially with data from Keynote using pembrolizumab.